Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. I'm your host today, Eric Lim, and it's a great delight and a pleasure for me to invite Dr. David Planchard from the Institute Gustave Roussy in France. He is the head of the Thoracic Pathology Committee and president of the International Center for Thoracic Cancers, talking to us a bit about multi-modality targeted regimens focusing on EGFR mutations. As always, these sessions are brought to you by our sponsors, and you have Premier Education at no cost. Thank you to AstraZeneca, Medtronic, and also Medela, the sites of care. And without further ado, and thank you for coordinating us within your multiple talks today, Professor David Planchard.
Thank you so much, Eric. Thanks for the invitation. It's a great pleasure to have this short discussion about the lung cancer and the multimodality treatment, which becoming quite complex nowadays. So I will try to make the shorter as possible because there is so many things to tell about the non-small cell lung cancer nowadays with the targeted treatments. So you know the complexity for which, for sure, we need to have the pathological diagnostic, a good staging, and particularly to be sure that we have the molecular portrait of each patient to have the best treatment upfront and whatever the stage nowadays in non-small cell lung cancer, and particularly adenocarcinoma. If you are doing, I would say, NGS molecular analysis panel, you might be able to identify potential actionable genomic alteration in nearly, I would say, 60% of patients for which you can discuss potentially targeted treatment. So I would say nowadays we have a top 10 target. This is ESMO guidelines for which we might discuss first line, second line with a specific targeted treatment. This is for the metastatic disease, but for sure nowadays we are pushing for the locally advanced and also for the early stage, particularly for the EGFR population with the third generation with osimertinib, for example. And the deal is how we can improve the PFS, how we can improve the overall survival, better control the mechanism of escape, better control, particularly the mechanism of resistance with targeted treatment. We know nowadays we are looking more and more for the persister cell to try to early intensify the treatment. And this is what we try to do nowadays with combination, for example, TKI plus chemotherapy, we will see in the FLORA2 trial, to try to avoid the mechanism of resistance, because when the cells, tumor cells develop this mechanism of resistance, we're always running after the mechanism of acquired resistance. So that's why we need to nowadays intensify the treatment up front with a new generation EGFR TKI, and particularly with combination. And nice example for which we did a lot of trial. This is for the BRAF, BRAF V600E. You know, it's around 2% of patients with non-small cell lung cancer. If you target this population with monotherapy with a BRAF inhibitor, dabrafenib, it works. 33% response rate, median PFS 5.5 months. But we know quickly this population, these tumor cells will lead to an activation of the downstream pathway, particularly MEK1, MEK2. And so what has been done on the next step was to have an association BRAF inhibitor and MEK inhibitor. And in this case, just look at the result. You double the response rate and you nearly double the progression-free survival. 10 months versus 5 months response rate, 68% response rate versus around, I would say, 35% response rate with monotherapy. We have did also a specific French trial. Previously, it was dabra plus trametinib, and we did another trial with encorafenib plus binimetinib, BRAF inhibitor plus MEK inhibitor, and we confirm clearly you improve the response rate and you improve progression-free survival, which is nowadays standard of care in our population to start with a combination BRAF inhibitor plus MEK inhibitor to improve the response rate, PFS, and finally improve overall survival. What about the EGFR? Because the EGFR, this is the most advanced disease in the development, and we have a nice knowledge in this population. We know it's complex because we have the classical EGFR mutation nowadays, deletion 19, exon 21, mutation of resistant, T790M mutation, exon 20 insertion, and the uncommon mutation, mainly called nowadays as the PAC mutation. So we need clearly to identify which type of EGFR mutation we're fighting, because we'll have some specific inhibitor and specific combination. If we're just focusing on the sensitive mutation, you know the trial that was the first trial that showed in this population gefitinib versus carboplatin paclitaxel did better in this population with an EGFR mutation at opposite. If you are EGFR wild type, you do worse with gefitinib versus carboplatin and paclitaxel. But whatever, even in this population who are EGFR mutated that receive the third generation, you can see you have this population with primarily resistant. You do not do better for the PFS versus chemotherapy. And on the other side, you never cured patient. You always have a recurrency for which they develop, unfortunately, the acquired resistant mechanism. And the most frequent acquired mechanism of resistance for this population that receive the third generation EGFR TKI is the T790M mutation on exon 20. And for this, osimertinib have been specifically developed, highly specific for this resistance mutation, then you can see you can reach 70% response rate if you compare to platinum-based chemotherapy in this population previously treated, T790M positive. Clearly, you significantly improve the PFS versus platinum-based chemotherapy. So the next step was to push upfront the third generation with osimertinib to try to anticipate the mechanism of resistance, and clearly you do better. FLORA trial that compare osimertinib to gefitinib or erlotinib, significant improvement PFS, significant improvement in overall survival. This is the best strategy to try to anticipate the mechanism of resistance with the T790M positivity. So you can think still about the sequence of treatment, but not the best. And for sure, you need to have the best treatment upfront to avoid the development of resistance and to try and to improve, I would say, overall survival in this population first line. If you are thinking sequence of treatment, can we do something with circulating tumor DNA? This is something that has been done in the APPLE trial, for which it was compared osimertinib versus a sequence of treatment, third generation, followed by third generation with monitoring by ctDNA or classical monitoring by CT scan. But whatever, the trial do not show any improvement in PFS and overall survival. It was quite comparable, which is nice, but it was detrimental for the brain PFS. You can see in this case, clearly you do better to prevent the brain mets with the third generation in comparison to a sequence of treatment with hazard ratio 0.54. So this on the fact to start with the best treatment, particularly to block the mechanism of resistance and also to have the best brain penetration, which is the case with osimertinib, for example. So can we do better nowadays? If you compare osimertinib first line, can we do different association of treatment? The most promising was developed association with platinum-based chemotherapy again to try to kill potentially the persister cells and to try to avoid the development of resistance to the targeted treatment. And this is something we did in the FLORA2 trial, FLORA2 safety run initially, followed by the FLORA2 trial, randomized osimertinib versus OC plus platinum-based chemotherapy. And the trial significantly showed an improvement in PFS, whatever investigator, Birk assessment, you can see you improve the PFS around 9 months if you start with platinum-based chemotherapy plus osimertinib in first line versus osimertinib, and particularly for two subpopulations of interest that are generally less sensitive to the EGFR TKI, exon 21 mutation, improvement 11 months PFS, and also for the patient with the brain mets. Median improvement, you can see 11 months in this population if you start with chemotherapy plus osimertinib to try to block this population with brain mets. And just look the intracranial brain response, complete intracranial brain response, you reach around 50% complete intracranial brain response with a combination versus 16% with osimertinib, which is currently the best treatment for this population. So this is a nice way to better control, particularly patients with brain mets. And recently at ALCR, it was also showed same type of trial with the third generation, different. It was omolertinib plus OMAN chemotherapy. They showed exactly the same amount of benefit in comparison to the FLORA2 trial with a highly significant improvement in PFS, whatever the type of EGFR mutation. In terms of overall survival, currently not reached, but you can see a nice trend in favor of combination to improve overall survival. So clearly, we need to intensify the treatment upfront in our population. And we have another option, which is also AMI and lazertinib, with bispecific that target EGFR and MET in combination with lazertinib. The trial showed also significant improvement in PFS And they also updated the data, which is mature for the overall survival, that was also improved with the combination of amilasertinib. Things to take in cautious for the discussion. In the Mariposa trial, the crossover was not allowed. Patients that receive osimertinib were not allowed to receive amivantamab in comparison in association to chemotherapy, which is nowadays a standard of care in second-line treatment. So keep this in mind, and particularly for the brain mets, probably less convincing to have this type of combination of ami and lazertinib. You can see in terms of the intracranial progression-free survival, really convincing in the FLORA2 trial, which is something really important. In this population, 40% of patients with EGFR have brain mets at baseline. We should take in account where we're thinking about intensification. It's much more toxic for the patient. We might impact the quality of life, mainly in terms of digestive and hematological toxicity when you had chemotherapy, but we know how to manage chemotherapy. When you do the amilasertinib, it's a toxic combination, particularly in terms of digestive and particularly in terms of rash toxicity, in terms of grade 3 or higher toxicity, 61% skin toxicity, paronychia. You have the infusion reaction in nearly 60% of patients, venous thromboembolism also. So you need to prevent all these toxicities. So this is something to keep in mind and discuss with the patient before to have this type of combination and intensification of treatment in first line. The other things, so we improve the PFS, potentially improve overall survival. We prevent, we delay the mechanism of resistance. But what are the mechanisms of resistance? Do we generate a more aggressive disease on the molecular point of view? Particularly the FLORA2 trial, we look on ctDNA, and finally, we found exactly the same acquired mechanism of resistance in comparison to osimertinib, but fewer, I would say, mechanism of resistance, and particularly fewer combination of mechanism of resistance. So much more simple, I would say, disease of resistance, or probably much more simple to treat this patient when they progress after chemotherapy and osimertinib, not a more aggressive disease on the molecular point of view, which is quite nice for the further line of treatment and discussion. The other things we looked, ctDNA. ctDNA, can we predict in which patient we need to have this association of combination? If patient at baseline are ctDNA negative, they have a better PFS in comparison to the patient who are ctDNA positive, which makes sense. If you have a higher tumor burden, you do worse in patients who are ctDNA negative, 18 months versus 13 months. But the most important, we look, can't we predict the benefit to hard chemotherapy in this population? The answer is yes. Potentially on the left, patients who are baseline ctDNA did better if they receive chemotherapy with osimertinib versus osimertinib. At opposite, patients were ctDNA negative, not so clear that you bring a benefit to hard chemotherapy. So more aggressive disease, you need to hard chemotherapy. Less aggressive disease, ctDNA negative, probably you can just treat patient with osimertinib monotherapy, which is quite nice for the discussion. The clearance of ctDNA at week 3 was only prognostic. It was not predictive of the magnitude of benefit to hard chemotherapy. So what to do beyond? Mechanism of resistance, new EGFR mutation, MET amplification, L2 amplification, some red translocation. You have also the small cell lung transformation, histological transformation. So we need to rebiopsy tissue, liquid biopsy to adapt the treatment. And again, things about combination in this patient, particularly when they develop the MET amplification, 15% of patients will develop this MET amplification, and you can see combination of OC plus salvolitinib or OC plus tepotinib, you reach around 50% response rate, median PFS, around 6 months post-osimertinib. You can do this molecular testing by liquid biopsy. You can test for the MET amplification, the red translocation, and just look OC plus tepotinib, 50% response rate, OC plus selpercatinib, you reach also around 50% response rate post-osimertinib. So importantly, to do liquid tissue biopsy to potentially keep this type of intensification combination of treatment. Savannah trial recently that have been presented at ELCC meeting, MET positive by immunohistochemistry or by FISH, just look this population that received a combination OC plus salvolitinib, 50%, 55% response rate, median PFS, 7.5 months, really promising, waiting the ongoing phase 3 trial. What about the Mariposa 2? again, nice MET inhibitor with amivantamab, ami plus chemotherapy did better than chemotherapy. It's another option in this population, post-osimertinib, first line of treatment. What about the ADC? Many ADC are coming. Highly sensitive population to our EGFR mutated, ADC that target F3, TROP2, bispecific, EGFR F3, and target MET. All these type of ADC have shown response rate around 40 to 50%, median PFS around 5 to 6 months. Same combination. We should keep probably osimertinib and had potentially datopotamab deruxtecan, which target TROP2. Just look in this ORCA trial. 6 milligram per kg of datopotamab deruxtecan, response rate 36%, median PFS 11.7 months. So within nowadays, waiting the randomized ongoing phase 3 trial for this type of strategy in this population. So that means nowadays, this is where we are, how to optimize with multi-strategy in this population. Osimertinib still the standard of care. We might discuss, particularly for the brain mets, particularly for the exon 21 mutation, particularly for the high tumor burden, ctDNA, aggressive disease, combination, intensification with OC plus chemotherapy, which will be my choice. Otherwise, you have potentially AMI and lazertinib, but need to keep in mind the high level of toxicity and all the prevention, otherwise might be difficult for the patient first line. So you can see all the strategy, first line of treatment, intensification. Clearly, this is the only way to prevent the mechanism of resistance and to improve PFS and to improve overall survival. And depending on the strategy, you can discuss what are the further line of treatment, second, third line of treatment, for which nowadays we have more and more options, which is quite nice for the patient. Some option in clinical trial, but hope these different options might come in clinical practice if we have positive randomized phase 3 trial ongoing. So keep in mind, combination for sure, improve PFS, improve OS. Keep in mind also, we might impact quality of life. We have an impact on the cost effectiveness. And what about the later line of treatment? All this should and must be discussed for sure with the patient. And lastly and quickly, for the uncommon mutation, we have the exon 20 insertion, we have the uncommon mutation. We are testing this population. We identify this uncommon mutation. And nowadays also, we'll have some combination of specific treatment, particularly for the exon 20 insertion, for which combination of chemotherapy plus amivantamab have shown a significant improvement in the response rate, improvement in progression-free survival. This is nowadays standard of care. Ami plus chemotherapy strategy in first line of treatment in this population with exon 20 insertion. For the uncommon mutation, it's becoming complex because you have major uncommon, you have the rare uncommon, and you have the compound mutation, uncommon, plus common mutation. So we'll have to discuss what are the best strategy in all these more rare disease with this specific uncommon mutation and particularly compound mutation. In few words, we have high efficiency potentially with afatinib that have shown nice data in this uncommon mutation in some pooled data with a response rate between 50 to 80% response rate. But also it was shown in a randomized trial that you did better in this case, afatinib versus platinum-based chemotherapy, which might be considered as a standard of care in this uncommon EGFR mutation, but also osimertinib have shown promising data. This is the most important data with a response rate around 50%, median PFS around 9 months. So we can discuss also osimertinib in this population. And if I just want to share quickly one cases, for example, this patient had an uncommon mutation. You can see a huge primary disease on the right. She had some pulmonary nodes. So initially it was difficult to know if it was metastatic, non-metastatic disease. So we decided to start treatment with osimertinib. She had a magic response. And finally, with only this right pulmonary lesion. And finally, we decided to operate this patient. She had been completely cured 2 years ago. And after she received adjuvant treatment with a chemotherapy, and more than 2 years after the surgery, induction with osimertinib in this uncommon mutation, and this patient is still in complete response. So you can see the multimodality also. We can discuss induction surgery, which make the things much more complex. So you see the complexity for this population, classical mutation, uncommon mutation, exon 20 insertion, for which more and more we are going with combination to better control the disease. And lastly, we are pushing all this targeted treatment in the early stage, stage 1B to stage 3A. This is the result, a magic result of ADORA trial, improve DFS, improve overall survival in patients with classical EGFR mutation to receive osimertinib after surgery. And more recently, in the unresectable stage 3, the LAURA trial also that showed quite impressive data in disease-free survival, currently immature for the overall survival, but that will become also a standard of care in this unresectable population with an EGFR mutation, chemo-RT, followed by osimertinib. So you see, whatever the stage, we will adapt the strategy of treatment to improve the PFS, improve overall survival. So many things to discuss nowadays. I just show you an example of the BRAF. We have the example of the EGFR, but for sure we have many other examples for the molecular alteration. And for sure, we need to look at the site of mets, type of mutation, the commutation, ctDNA. We need to take in account the side effect. We need to take in account the later line of treatment in terms of strategy, need to take in account the accessibility of the treatment, and for sure, need to take in account the comorbidity, performance status of the patient, and patient preferences. Some patients, for example, even if you do better with OC chemo, don't want any chemotherapy in infusion, and for this case, you need to respect and start with osimertinib monotherapy, for example. So no one size fits all. It's cases by cases that make the things much more complex, but this is the only way to improve the overall survival in our patient and to cure much more patients, and particularly for the early stage. And with this, I think I will end it here to try to keep on time. And thanks so much for the invitation and open for all the questions. And thanks to all the team from Gustave Roussy. Thank you.
Thank you so much. That's an amazing overview. I'm always so blown away by the amount of progress I've made in the advanced disease and the number of molecules. Invariably, the best of the best in the advanced setting will always be then transported into the early stage resectable setting, with the impression that screening may actually transform the stage shift to the majority at some point being resectable lung cancer, and I'm not sure how far that is away. One of the first questions coming from the audience, and Dr. Addy is asking a little bit about multiple drug combinations or multiple drug targets. I'm also super fascinated. How are the multiple, well, firstly, how common would you have more than one target? And how do you choose which targets to, select and to treat?
This is something we are seeing more and more because for sure we are doing more and more large panel NGS testing. It's always the thing to discuss. Do we have two, I would say, actionable genomic alteration, or do we have one actionable genomic alteration and commutation? If you have a specific commutation, the commutation might, I would say, does not change the way you treat the patient for the main common mutation. It's just the way do we need to intensify another treatment. If I have an EGFR mutated classical mutation, but if I have a TP3 mutation, for example, I might discuss I might be more intensified because this patient might have an early relapse. This is the first thing. It's just the way of the intensification. If after you have two major common actionable genomic mutation, for example, you have an EGFR and you have a HAL translocation, in this case, it's cases by cases, depending on the technique you have used. And sometimes you might add some additional molecular testing to confirm, because sometimes you might have immunohistochemistry positive for the HALK. And so in this case, you will look for the fish, you will look of the result of RNA sequencing. Do you confirm what have been observed by immunohistochemistry to confirm the other actionable genomic alteration? And sometimes finally, you can see you have some false negative depending on the technique. So that's why my recommendation and what we're doing, for example, at Gustave Roussy, all these cases, whatever, they're discussing in a molecular tumor board. And the biologist can help you and tell you, can we trust the result of the techniques? Or finally, we cannot trust because the quality of the DNA or the RNA is not enough. And we need to add another technique to confirm if we really have two different clones and two different actionable genomic alterations. So that's why nowadays, discussion on molecular tumor board clearly help us to determine how to treat the patient and what we should trust when we see the result depending on the techniques.
Right. And can I ask, moving on to the EGFR mutation, which is the focus of your talk today, is EGFR resistance invariably occurring? And what's the rationale of 3 years treatment for adjuvant osimertinib?
I would say, is it systematically occurring? The answer is no. We all have some patients that receive 5 years, 10 years of treatment, even in metastatic disease with no recurrency of EGFR mutation. So that means nowadays, the duration of exposure for the adjuvant, I would say it's much more empiric. We learned before that 2 years with the third generation is not enough. So that's why they're pushing for the 3 years of adjuvant treatment. And if you're looking for the LAURA trial after chemo-RT, nowadays there is no limit of exposure. It's until disease progression or until toxicity. But is it feasible to expose all these populations and some patients, for sure they will be cured, to expose for all the life with osimertinib? That's a huge question. So that means nowadays, we don't know exactly what is the optimal treatment. And there is, for example, another trial after resected patient to expose until 5 years with osimertinib. So that means probably we can consider a patient to be cured after 5 years. So the optimal treatment exposure after surgery might be between 3 to 5 years. We don't have currently the question. Probably and hope we can be helped by the circulating tumor DNA or the MRD after surgery to better identify which patients are completely cured or which patients are not cured and should receive for sure with a prolonged exposure to osimertinib. So MRD blood testing after surgery might be something important in the near future to better determine the optimization of the duration of exposure. But this is something really major, particularly in terms of cost toxicity.
And also in the resectable setting, there's like several studies like NEO-ADAURA, ADAURA-2, looking at osimertinib prescription before surgery, before and after surgery, and in stage 1. I mean, in your opinion, if it is a long-term treatment, would there be any additional benefits in, treating patients a few weeks ahead before an operation?
I agree. I'm not per sure. So that means if you compare to chemoimmunotherapy in the neoadjuvant field, for which only 3-4 cycles is enough to induce a high rate of major pathological response or complete pathological response, if you expose only with 2 months of osimertinib, generally is close to be 0% of complete pathological response. So I think the objective is not finally to make the patient to be in complete pathological response, but probably patient to be non-resectable to become resectable. And I think this is exactly the cases I showed you. That we have other cases for which you might consider to be non-resectable. The response rate is high. The probability to be in complete pathological response is low, but it's only the way to push patient unresectable to become resectable in these cases, which is different from the chemo IO in the other population. And I think we have this population for which we can probably push to become resectable with the induction. So let's wait the result of the NEO-ADAURA. And NEO-ADAURA, they also include an arm with osimertinib plus chemotherapy. So probably with the fact to have chemotherapy might do better in terms of PCR.
No, that's definitely fascinating, because the whole induction piece where you change from non-resectable to resectable can then be also extended into the advanced disease setting where you become oligometastatic. And I think that we are all looking into this field extensively at the moment. We got some questions from Dr. Harapin, who's asking about broad-based NGS testing. You mentioned ctDNA positive and negative, but every study seems to use a different system, different panel. How would we be able to translate that into day-to-day clinical practice, like what you're doing at the Gustave Roussy?
That's why we need, that's why it's still experimental. So that's why nowadays it's not, I would say, through recommendation, because for sure, depending on the technique or the quality of the ctDNA techniques you will use, and particularly the sensitivity of the techniques, you might detect ctDNA or not detect ctDNA. So that's why nowadays, for example, at Gustave Roussy, we use the technique by a Foundation Medicine liquid biopsy. And this is the techniques we use to look at the presence or not of ctDNA, and particularly try to identify the molecular alteration in this population. But whatever, we are not currently using in routine practice ctDNA positive or negative to discuss the treatment. I think we need to standardize the treatment to be sure we capture the right population, that do not miss some patient to not receive chemo and osimertinib. I'm totally agree. So it's still experimental, but I think this is where we are going in the near future to help and to better determine which patient should be intensified or not intensified. Same thing for the perioperative treatment, same thing after chemo-RT. The way we are looking the MLD it's not standardized. So depending on the technique, so that's why we have to take it by cautious. Otherwise, we're not selecting the right and the good population. Totally agree.
Question from Dr. Sultanis. In the advanced disease, you follow the molecular profile so closely. In the resected disease and adjuvant treatment, would we at some point be expected to do the same to profile the tumors as we go along during the follow-up period?
I would say the idea is probably to make a molecular profile and ctDNA, something like this, when you want to stop the treatment. So that means after, we might imagine after 1, 2, or 3 years, I don't know, of exposure of osimertinib, so I am sure the patient is completely cured, there is nothing circulating. I would be happy in this case, before to stop the treatment, to have a blood testing with MLD, ctDNA, whatever. In 3 years, the techniques we might improve to be sure the patient is completely negative on the blood testing, in addition to performing a classical imaging before to stop the treatment, because some patients probably they're not cured, and for which if you still have ctDNA MLD positive, you might continue the treatment. So this is probably something we are looking for before to stop all the adjuvant treatment.
A question from Dr. Patel. EGFR mutations are common in adenocarcinoma, but can also occur in squamous. Is the policy of reflex testing for all resectable patients the way forward?
I would say yes, and particularly if you have a light or never smoker. I had exactly the same cases recently of a patient that was referred to Gustave Roussy. He was a squamous, a never smoker. The local oncologists do not want to perform any molecular testing. I say, okay, we will start chemotherapy and immunotherapy. I say, no, you cannot start this type of treatment before to have at least a minimum portrait. We need to exclude any HAL, ROS1, and EGFR mutation, and so on. We did the molecular testing. The patient was EGFR mutated, classical mutation, squamous disease. He started osimertinib, nearly a complete response. I just saw him a few weeks ago after 3 months of treatment, and the patient was happy. So clearly, if you have an EV smoker, squamous, you can discuss, but we still recommend the reflex testing. But if you have a light never smoker with a squamous, you cannot trust and you cannot stop here. You need to perform the same molecular testing as you do for an adenocarcinoma. Otherwise, you will miss this type of population with heterogeneous disease, or sometimes the quality of the tissue biopsy is so small by bronchoscopy. So finally, it's difficult to completely confirm it's a squamous. So be cautious with this. Totally agree.
Excellent. Thank you so much. As always, there are too many questions. You really engage the audience. We can't answer them all in the time limit we have here. It's a fascinating talk.
Thank you.
Thank you so much. And also, once again, thanks to our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. Next week, we have Heather Wakely talking to us about the immunotherapy aspects in multi-modality treatment. And once again, thank you for fitting us into your busy schedule today with China. It's an amazing talk. Thank you so much, David.
It was my pleasure. Thank you so much. Have a nice day. See you soon, everybody. Bye-bye.